Good morning. My name is Carol DeFelice. I'm a ThyCa volunteer. I'm from Massachusetts, as is our speaker today. Our speaker is Brenna Neufeld. She's a nurse practitioner at the Dana-Farber Cancer Institute in Boston. She works in the Division of Head and Neck Oncology with a population focus of advanced thyroid cancer. Her clinical interests include symptom management and optimizing the integration of palliative care in her patient population through their continuum of care. If anyone has a question at any point, we're going to obviously let her do her talk. We will bring a microphone out to you, as you know, if you've been to this conference. So we're going to welcome Brenna. Thank you.
Morning, everybody. How are you doing this morning? I know it's the third day, so we hanging on? Okay. As you mentioned, we're going to hold class questions to the end, so if we're okay with that, but I will be more than happy to answer as much as I possibly can. So as I said, we're going to go over the roles of TKIs in advanced thyroid cancer, but mostly I'm going to focus on the practical management of the adverse effects of these TKIs, because as I'm sure many of you are aware, with all medications, there are adverse effects for any kind of medications our patients are on. So just as an overview, the tyrosine kinase inhibitors, there are multi and specific tyrosine kinase inhibitors. So I'll briefly go over that, and then I'll really focus on the adverse effects, the multidisciplinary approach that our group really takes into account, the monitoring and the follow-up, and then really the quality of life that our patients we try to focus on for our patient population. There's a lot on this slide, just going to briefly go over it. So just advanced thyroid cancer, what it really boils down to. It really comes down to different categories. So the structural or the surgical categories, the biochemical categories, the histological and molecular categories. If the patient has either distant mets, rapid progression on imaging, if the tumors are refractory to RAI, if the have poorly differentiated or aggressive histological features, and then again, all anaplastic. Okay.
Are you able to stand over here?
I can.
The camera, is that okay?
I can do whatever you want me to do.
Perfect.
Is that okay?
Yes.
All right.
That way virtual members can see you.
Hi, virtual members. Okay. Okay. I like to move, so I apologize if I go off
That's
screen.
all right. A little bit of both is good.
Okay, and then all anaplastic thyroid carcinoma is also within this advanced thyroid cancer. So again, the multiple tyrosine kinase inhibitors, the FDA approved ones, the sorafenib, the lenvatinib, the cabozantinib for a second line DTC, and then the vendetinib. So as you can see, I don't know if this works. Nope. So there are numerous receptors that these kind of cover. So as you can imagine, they're going to have more side effects when these medications are used. When compared to the specific tyrosine kinase inhibitors, you have the pralsetinib, the selpercatinib, you have the entrectinib, the dabrafenib, the trametinib. These, as you can see, they're point specific, right? So comparatively, this is more if you're outside playing with a sprinkler versus a water gun, right? The water gun, you can kind of hit things piece by piece. You might have a little bit of collateral damage and things might get wet. Whereas, whoops, this one, the sprinkler is going to be your dad's open windows are going to get his car wet. Your mom's laundry is going to get wet. Everything else is going to get wet. So yes, you might hit the target, but other things are going to get wet at the same time. This, I'm sure you've seen this in other, or forms of it in other talks this weekend. But again, these are just, I'm going off the screen, so I apologize. These are just the targeted therapy. So again, the dabrafenib, the trametinib, and then you have, if you can see, I don't have a pointer, but the lenvatinib is here, 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 and here. So if again, you have all these, you have these non-specific, for lack of better terms, receptors that are going to be more influenced in terms of side effects when you have medications like lenvatinib and sorafenib versus something like a dabrafenib or trametinib. Okay. Hands up if you've ever taken a medication in your life. Anything. Keep those hands up if you've ever taken a medication in your life and it had some sort of negative side effect. Shocker. Hands up if you ever take a medication in your life, had some sort of negative side effect, and you've thought to yourself, I'm willing to risk stopping this medication because it's impacting my life so negatively that I'm willing to see kind of how it goes.
Sorry, we're sharing the wrong screen. I'm gonna fix it. You can keep going.
Okay.
Sorry.
I'm batting 1,000 with this. So basically, that's kind of where it comes down to with some of these TKIs, right? So we want to make sure some of these side effects that they have, these are a list of some of the side effects that these TKIs have. You're not going to get all, some people get all of them, unfortunately. Some people get none of them. Some people get a mixed bag, right? But it's our job as clinicians to really focus on how do we manage those side effects so that people can really, outweigh the cost benefit balance, right? So they get the most cost and the least cost and the most benefit when they're on these medications. So some of the side effects of these medications are GI related, dermatological related, they're cardiotoxic, they can have renal impacts, they can cause hemorrhaging, they can cause GI perforations. I don't do this to scare you. It's kind of like an information slide. They can impact wound healing. As always, I feel like every medication has some sort of fatigue aspect. They can cause myalgias, so like muscle aching, and they can cause impact in your blood counts as well. Some of them can. Sorry, I thought someone was taking a picture. So in terms of the medications that we went through on the other slide, sorafenib, some of the major ones, hypertension, hand-foot syndrome, diarrhea, fatigue. Lenvatinib, hypertension, hand-foot syndrome, diarrhea, fatigue, proteinuria. Cabozantinib, hypertension, hand-foot syndrome, diarrhea, fatigue. Are we seeing a pattern? Correct.
What is hand-foot syndrome?
So I will go into that.
Okay.
Can I put a pin in that?
Yeah.
I will go over it. These, if you notice, a lot of them have overlapping syndromes, right? Again, don't need to show the slide to overwhelm you. It's just to show you the side effect profiles tend to overlap with a lot of the medications. So the gastrointestinal effect, a lot of these medications have side effects in terms of diarrhea, constipation, nausea, weight loss, anorexia, appetite suppression. However, that being said, the diarrhea it's a really delicate balance, right? We need to be careful for electrolyte imbalances, fluid loss. We need to rule out any kind of infectious process. A lot of the diarrhea is dose dependent as well. So the higher dosing that you're on, sometimes the more side effects you can have in terms of the amount of diarrhea that you're having. A lot of times we can have patients have interventions such as Imodium, Lamodal, opium tinctures, that kind of stuff. So it's really important for us as a clinical team to really be on top of and intervene quickly. So that way things don't go, you don't have any of these GI side effects for a week, 2 weeks, 3 weeks, and then you come in 10 pounds down, extremely fatigued, that we could have intervened, 2-3 days into it and kind of gotten ahead of the game. Same as constipation. A lot of these patients have had previous treatment, right? So surgery, radiation, chemo and radiation. So some people have bone mets. So they're dealing with chronic pain, acute pain. So they're on all these opiates. And that can be a secondary effect for constipation. So we want to make sure, again, that these patients are not going 7 to 10 days without a bowel movement, because that's going to snowball into more nausea. Then it's going to turn into anorexia, and then it's going to turn into weight loss. And it's going to be this effect that, if we were able to nip it in the bud, it could have been an easy fix, relatively easy fix, versus chasing it 2-3 weeks down the road. My nurse navigator always gives me a hard time. We joke about it, that I always tell my patients, if we flirt with the 72-hour mark in terms of not having a bowel movement, we need to do something. All right. I always tell my patients that 72 hours is that's my cutoff. After that, I need to know, and I will intervene, because no one feels good after that. Okay. Nausea, weight loss. I'll go into how we intervene with all of these, but I just wanted to kind of make you aware. This is hand-foot syndrome, my friend, right here on the right. So that's basically kind of a grade 3. Grade 1 and 2, hand-foot syndrome can be as benign, and I mean that in the most, benign sense, but it can be as easy as tingling in your hands and feet, or just redness, but it doesn't feel like anything. Or you could basically have blistering and peeling of your hands and feet. You can have stomatitis or mucositis. So discomfort, burning, oral sores in your mouth, in your throat. You can have it in your entire GI tract. You can have this EGFR eye rash, which is the one on the left-hand side. You can also just have frank itching of your skin, which is the pruritus. You have no overt rash, but just everything feels itchy, everything is dry. So we tend to have, again, these right here, some of these we can't, no matter what interventions we do at the beginning, we can't avoid some things, but a lot of the times we can be very proactive to try to stave off the severity of some of these side effects. And again, I will go into what we do and stuff a little bit down the line. Cardiac and renal issues. So with these medications, hypertension goes hand in hand with these TKIs. It is known that real-life studies have shown that about 72% of patients who are on lenvatinib get some sort of degree of hypertension. I believe it's 21% get a grade 3 or higher. So when we start, if a patient is going to be started on lenvatinib and already has hypertension, we want to make sure it's very well managed before we even initiate some sort of medication. If a patient is not hypertensive prior to, and we start them, we want to have very close follow-up at the dose escalation phase, because they can become extremely hypertensive very, very quickly, especially if they're on higher doses. Other things are proteinuria. It's a known side effect for, due to the vasoconstricting nature of these MKIs for the hypertension, but also vasoconstriction in the kidneys to cause this proteinuria, which is basically you dump protein into your urine. So we do baseline urine studies on these patients before even starting this medication, because it will dictate what antihypertensive we actually start you on if need be. QTC prolongation. So some of these medication causes changes in your EKGs. So we do baseline EKGs and echoes as well to make sure if we have a comparison going forward, if for some reason you have either cardiac issues later on, was that there when you started, or did the medication possibly change it? And then electrolyte imbalances. Again, if you're having all this diarrhea, if you're having all this, lack of nutrition, that kind of stuff, that can change your cardiac makeup, and that can cause different changes in your EKG. So as I mentioned, for cardiac screening before this medication, we do a very thorough history and physical exam. We do an EKG and an echo usually at baseline, in addition to a baseline urinalysis. And then we follow up usually at restaging. So basically every 3 months to do serial testing to make sure that patients are stable when they're on this medication. And then of course, if you're presenting to the clinic in between that time frame and you're having any kind of cardiac issues, palpitations, chest pain, we will intervene at that time as well. Hemorrhaging. So again, due to the anti-angiogenic effects of these drugs, response can be twofold. So you can have a great response, right? You could have this very visible tumor and you start this medication and the tumor shrinks extremely quickly, and that's great. But then in addition, inadvertently, you can sometimes have these very destructive adverse effects. So you can have a high risk for hemorrhage, especially if your tumor is encases major blood vessels, or if you have brain metastases. You could be at risk for GI perforation if you have a history of inflammatory conditions such as ulcerative colitis, Crohn's, diverticulitis. And then you're at a higher risk for fistula formations if your tumor is known to already invade some of your GI tract or respiratory tract. So if it's in your trachea, already in your larynx, if it's in any of your GI tract, again, the medication could be working very, very well, but in that same time point, it's already going to then invade the lining of whatever tract it's already going into. And then wound healing. Again, due to these anti-angiogenic effects of these drugs, depending on the severity of the procedure, surgery, or radiation that you may need to incur, you're going to have to hold these medications prior to and then post whatever these procedures you're going to have because of the healing process. And you're going to just discuss this with your clinical team, depending on what procedure you're about to undergo. And then lovely fatigue. Everybody knows this, everybody loves this, right? So fatigue on so many levels. Fatigue because of, exactly, you just sighed. I mean, that just sums it up in a nutshell, right? So fatigue on so many levels. Besides the direct effects from the medications themselves, that just is a side effect itself, you have insomnia, right? Could be due to xerostomia, the fact that you have this dry mouth from either previous RAI, previous radiation, the drugs itself. You have to get up every 2 or 3 hours because your mouth is a Sahara Desert. Or fluctuating TSH levels. If your TSH is too high, then you're so tired you can't get out of bed. If your TSH is too low, then you're running around everywhere and you're having heart palpitations and you can't get to bed, right? Stress and anxiety. How good is your sleep if you're stressed and anxious? Lovely, right? On so many levels. So if you have, and you have stress in many forms, you have the medical stress, you have the financial stress, you have family stress, you have work stress. So it's not just the fatigue that comes along with the medication itself. There's already other factors that also snowball into that. So we look at it as proactive versus reactive. As I mentioned before, we like to do as much as we can to get ahead of things and try to do our due diligence beforehand, rather than trying to be reactive, because we all know what happens when we're reactive. A lot of things can kind of fall apart. I mean, as I mentioned before, we can do our best to be as proactive as possible, and some things still go sideways and some things still fall apart and some side effects are still going to happen. But I feel like the more proactive we can be, we can lessen as many of those side effects as possible. So we take a multidisciplinary approach, as I'm sure a lot of places do. The top left group is really the main nuts and bolts group that we that work with our patients. So if the patient is followed by a medical endocrinologist, then they're also followed very closely hand in hand with an endocrinologist as well. However, if they're followed by an oncoendocrinologist, then they don't need to also be followed by an endocrinologist as well. That makes sense. Some patients are followed by a radiation oncologist. They're also followed by an ENT surgeon, and they have an advanced practitioner who they usually see most of the time. In our practice, it's an NP. Other practices, it's a PA. We have onc nurse navigators who do everything you can possibly imagine under the sun. They come in and see patients with us. They triage phone calls. I can't even imagine what my life would be without my onc nurse navigator, because basically she is my right-hand woman. So shout out to any onc nurse navigator that is out there, or whatever kind of staff nurse that's out there. And then primary infusion nurses, we try to do in continuity care. A lot of our patients who are on these oral agents don't usually have infusion appointments, right? But sometimes they need fluids, sometimes they need iron, whatever it may be. And we try to have those primary nurses assigned to them so they have a familiar face when they need to come into clinic. And then what our group tends to do is, on the very first couple of visits, we try to get at least the first 4 of the next group looped in. So speech and language pathologists, nutrition, pain and palliative care, and social work. Because it's very overwhelming, right? And this is going to be a long-term thing. This isn't just like you come in, you see me, and I'll see you in 4 years, right? And when you come in and see me for a consult, you have to bare your soul and tell your story and all this stuff. However, if, just say 3 months down the line, you need to see a social worker, or you need to see pain and palliative care, you don't want to then meet a new face and then bare your soul and tell your story all over again, right? You've been there, I'm sure. And I can only imagine how exhausting that is. So what we tend to do is try to loop everybody in, just so you have a familiar face, you know a person by name, they know your story already. And if you don't need them at the beginning, great, you don't need them. But 3, 4, 5, 6 months down the line, 2 years down the line, if you need someone, they know who You are already, they know your story. We keep them up to date. We keep them in the loop, and we just make the appointment. And they say, oh, hi, Jane. Hi, Bob. How are you? How are things? I've been reading up. And they just kind of take you as you are. You don't have to rehash the entire situation all over again. And then psychiatry, we bring that in if need be. A lot of times our social workers do a lot of the one-on-one handling, but if they need any kind of like medical intervention, we bring in psychiatry as well. And then the right-hand group is if we need further interventions by the specialties, because that's why they're specialties and that's why we have them. So metabolic support, if patients need pegs to put in, a lot of times our patients have issues either maintaining their weight and keeping up with if they have swallowing issues or whatnot. So we have the metabolic support, oral medicine. As much as I can sometimes be a Houdini and figure out, helping with either mucositis or xerostomia, the dry mouth. Sometimes I can't figure out the right concoction for every person. So I bring in oral medicine and have them be seen by them. Vocal therapy, we all know vocal therapy are godsend. So we refer right over to vocal therapy and have them do their interventions. Sometimes it's as simple, and I'm going to use simple very loosely, as voice lessons. The little harmonica, the straw, all that stuff. Or it could be, something as like an injection. And then we have interventional radiology and pathology. Those people are key in terms of the diagnosing or staging, and the pathology in terms of because that really dictates where our treatment is going to go. And then, as I mentioned before, with all the side effects, a lot of times we can manage a lot of the side effects. We manage a decent amount of the side effects. But sometimes, it becomes too much and too far out of my realm. And then it becomes defer to the specialist, because it's unsafe for me to start managing, 4 antihypertensives and, GI meds and renal meds. So I start to refer out. So cardiology, gastroenterology, nephrology. Some people need to see oncofertility, and then dental medicine if they've had history of radiation in the past. If they start to have issues with their teeth, we refer them out. And then close monitoring and follow-up. This is key, as I mentioned before. So as I mentioned, I'm going to take lenvatinib for a second. So short interval follow-ups, virtual visits in local labs, and home monitoring. So lenvatinib. Just say we take a patient on lenvatinib, we start them on there. We usually see any really of the TKIs. We do a week follow-up. We monitor their blood pressures. We see how they're doing. If everything's good, we start them. We usually tend to start them on a lower dose and then up titrate. And basically what we try to do is see what their highest dose they can be maintained on with the least amount of side effects. We try to get them to the max dose of 24. In terms of short interval follow-ups, we do weekly visits until they can be medically managed appropriately. They do home blood pressures and then send us those measurements. If we need to titrate antihypertensives, we do that as well. And then with restaging scans, if things are stable, then we can start to bump follow-ups out a little bit more. We can do virtual visits. I have patients who come hours away. I'm sure some of you drive a while to drive to your appointments. If we need to have local labs, we can do that as well. I don't need to have patients come to see me all the time. And then, as I mentioned, home monitoring. This is kind of where our onc nurse navigators really are pivotal, because they do a lot of those, touch base with them frequently and then update us. And then quality of life. A lot of you, as I'm sure, I have a lot of patients who come in and they were on active surveillance for a very long time and then had this change of diagnosis. Or I have a lot of patients who had no diagnosis before, and then, their medication profile was a multivitamin. And now they have a new diagnosis that they're now a chronic patient. So this new diagnosis comes with the changes in view of self, right? Where do they fit in now in terms of being a patient? Financial stressors, not so much for the FDA approved medications, sometimes depending on how insurance covers. But I have a lot of patients who, you know, we discuss their medical management. We think, you know, this is going to be your right course of action. And then we say, well, just in case you need to sign this waiver, so in case your, you know, insurance doesn't cover it, whatever, we've never had patients pay or whatnot, but just in case you may need to, just in case your insurance doesn't cover it, this medication, and they look at it and the medication is $5,000, $30,000, whatever it may be. So now you're looking and you're saying, okay, I need this medication and I shouldn't have to pay it, but I have to sign this waiver just in case. So that's another stressor that kind of is weighing over your head. Again, the ongoing fatigue of many levels, mental, physical, all of it. The vocal issues. Even though once we get patients onto a steady state physically, right? If we've kind of tweaked all the side effects and we've tweaked all the medications and things are going well, you know, the vocal issues. I have patients who are, you know, managers who manage a large group and they have to do talks like this daily. I can't imagine. I would have heart palpitations every day. I have patients who are teachers. I have patients who are train conductors. I have, you know, you have these patients who physically they can go back to work. And it's easy for me to say as a clinician, you're doing so well, get back out there. And they look at you and they're like, I want to, but I can't because I can't project what I want to say, or no one can hear me. Or they'll say, I can talk for an hour. I can talk for 2 hours, but I have 8 hours of meetings. By my 3 o'clock meeting, even if I have a mic, no one can hear me, or I'm so winded after 2 minutes, I can't talk. So those vocal issues are big, or swallowing issues, right? Even though people can physically swallow, they can't swallow normal, right? So how many of you are carrying water around? Or how many of you know, right? It's like a third leg, right? And I don't mean that in a negative way. If my patients don't have their water with them, I'm like, go out and get water. I don't really. I mean, I have mine. And it's food and eating is a cultural, social norm for us. And our patients are like, I don't want to go out. I don't want to go eat with my family. It takes me longer. Yes, I can eat what I want, but it takes me too long. I have to drink 4 bottles of water with my meal. I have to, you know, I don't want people to look at me differently. I don't want people to do this. Like, which is 100% understandable, you know? And as much as we tweak the medications for the side effects and we make those changes, sometimes we can't get you back to right where you were before. And that's very, very frustrating. Insomnia, as I mentioned prior, there's so many issues in terms of reasons why people have insomnia. That doesn't help because, I mean, ask a 3-year-old to an 80-year-old. If you're tired, I'm going to have a tantrum, period, end of statement. So I can't imagine trying to hold that tantrum as a grown adult inside all day long. And then people come up and they're like, how you feeling? Are you good? You're good, right? Okay. Like, that's when the tantrum wants to come out and you're like, please leave me alone. Everything's fine. Discomfort, right? You feel that? Discomfort. You have that chronic discomfort. So either if you had surgery or if you had any kind of radiation to your neck, it's going to tighten the muscles in your neck. It's going to tighten the levator. It's going to tighten the upper trap. It's going to tighten your sternocleidomastoid. It's going to tighten all of it, right? And then go right back up to the financial stressors or any of the other stressors. Where do you carry all your stress? In your neck. So what it's going to do, you're going to shrug. It's going to tighten everything else up, and everything else is going to get more tight. Are you agreeing? Bingo. Bingo. No, that's literally what my next statement was going to be. No, I was literally jumping into that. So I was a PT in my former life. So I hear you. So because what happens is these get all short, and then that causes not only discomfort and decreased range of motion, you're going to have headaches. You're going to have decreased range of motion in your neck. You're going to have short, you're going to then become even more mobile in the already mobile shoulders, which is going to cause more issues. You're going to become like back issues, all kinds of stuff. So plug, Physical therapy, huge, 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 huge. It gives you something to do for yourself, and B, it's going to help lengthen and strengthen and lengthen and move those muscles. The other thing we have, and I forgot to put it in here, is we have something called the Zakem Center, which is a place that does in our facility that has acupuncture, massage, and Reiki therapy. And I've been trying to tell our patients, you come here and you see me, which is a light in itself, but you need to do something for yourself, right? So even though it's within the Dana-Farber Cancer Institute, you can go there and get massage, or you can go there and get acupuncture, or you can go and get Reiki, just to do something for you that isn't necessarily cancer related, right? I feel like that's extremely helpful, not only for your body, but for your mind. And then like-minded support systems. This is my first time to a ThyCa conference, and I am absolutely blown away by the group of people that are here. Having like-minded people and support, and knowing other people who are going through the same thing, going through the struggles, so you don't have to continuously, explain what you're going through. They just know. They're living it. They know it. Or if they're caregivers, they know. They're like, say no more. So I feel like having that is huge. And I don't know if anybody was at Dr. Cabanillas's talk yesterday. Someone had asked, do you lose sleep at night? Yes. Yes, we do. And one of my patients is sitting here and she said, you don't have dark circles under your eyes. You don't lose sleep at night for me. And I said, that's called a lot of makeup. We lose sleep at night. We lose sleep we lose daytime, anytime. This one weighs heavy on me. Not only does the pathology weigh heavy on me, this is the biggest thing that weighs heavy on me. Your side effects do, because it impacts this. But I used to, as an infusion nurse, when I worked inpatient, I used to wake up with nightmares of the pump beeping all the time. I used to think my chemotherapy was wrong and the pump would be beeping. That's what used to wake me up at night. This now wakes me up at night constantly. I'm lucky that I work very closely with our surgeons and our radon, so I can keep them abreast of kind of how things are going, if they're if things kind of are going well or not. But for sure, I mean, even though it might not seem it at times, I lose a lot, and I don't want that to seem like, oh, poor me. It's just, I think about it often, and I think about ways that I can make it better in any possible way I can. So in summary, TKIs come with a cost benefit profile. And of course you have to weigh them for you at whatever point of life and whatever that you're in, whatever stage. Close monitoring and early interventions can help curb severe and adverse events. And as I mentioned, I believe that being proactive is extremely helpful versus reactive. Trial and error before finding the correct dosing and medication. So as I said, what could work for one person beautifully could be an absolute train wreck for another person. Each patient is unique. Work well with your medical team to determine what treatment course works best for you. Some people benefit greatly from drug holidays. Some people, I knew what your question was going to be. Some people really benefit from alternating drugs. So just say, if they can't tolerate, just say Lenvima, they can't tolerate, they're doing well on 14, but they can't tolerate 18. Let's try alternating 18, 14 or something along that line. So we're trying to get the max benefit, because we want them on the higher dose clearly to get the max benefit of response, but we also don't want them to be miserable 24/7, right? And then to all the patients, caregivers, everybody, you are not an island and you are not alone in this journey. Your treatment team is here to listen, to support, and to advocate you for overall needs. I always tell all my patients who are here and online or whatnot, you are the captain of your own ship, okay? Your medical team should advocate for you, but give you all the medical information you can possibly use to make the best informed decision for you, okay? But at the end of the day, even though I might think that Lenvima 24 is the best thing ever for you, and that's what I think you should do, if you personally, as a family, whatever, think that, thank you so much. That is not what I think. I think I should be on 18. Have that discussion. Have that discussion with your clinical team. Because at the end of the day, you are the one who is living this 24/7. Okay. Even though I have the pretty white coat and I have, all the bells and whistles and all the numbers and letters after my name, you're the one who has to live with this 24/7. Have that frank discussion with your team because it should be a very collaborative effort. All right. I thank you all so much for this opportunity. I feel extremely grateful, and I welcome any questions.
Okay, let me bring this out to you. We're going to start with live questions, and then we'll get to the people in our Zoom meeting.
I guess it's not so much a question as just a point of interest. I go to Mass General,
Sure.
and the nivolumab that I'm on
Yes.
has side effects of the chronic Crohn's disease type
Yes.
things. But they put me on another immunotherapy, infliximab, that
Mhm.
helped offset
Correct.
those. So there's a lot of things out there. You just need to really, like you said, tell your doctor that this is what's going on, and they can find something to help offset that.
Correct. Correct. There's a lot of times, again, especially with the immune inflammatory diseases, that's one, there are some, especially if they're clinical trials, sometimes there's very little wiggle room for that. But if it's as you mentioned, nivolumab, sometimes you can work with your doctor and if they're having a flare or whatnot. I've had patients who had immune-related ICI-induced either colitis or nephritis, whoever it may be. And we worked with the specialists or whatnot, and we got them on a very low dose, and they were able to continue the treatment without any further flares. So absolutely. We have more.
I'm just going to do one question here online, and then we'll get right back to you. There's actually a comment from a Brian G, and then he has a question. It says, I don't think we have ever had or been offered someone like you that approaches this form of this form in a multidisciplinary way. Each specialist mostly works in their own silo area of expertise. The center of our world is the oncologist. Any suggestions on how we can fix this? I guess they have to come to a large center like Dana-Farber,
Yeah.
maybe.
So Brian, I think it depends on kind of the center. So I'm lucky enough to work at a large scholastic institution that has all these outreaches that I'm able to reach out to the specialists and stuff. Some of the smaller institutions, I'm not exactly sure where he goes, and I don't need to know, but
Right.
some of the smaller ones, the medical oncologist or the oncoendocrinologist has to do, as he mentioned, it's a silo. So he has to do a lot of the work on his own and then kind of refer out to the community for other specialty input.
He does have a specific question. Do you know how common the effect of selpercatinib inhibiting T4 to T3 conversion is, and how to best address when trying to treat with thyroid hormones or supercatinib dosage?
I'm going to refer this question to my attending.
Yay.
Hi, that's a great question. So we actually have seen a pattern of somewhat funny thyroid function tests. So where you see kind of a dissociation between the T4 levels and the T3 levels. However, and we have some hypotheses about why this may be happening. We think there may be a defect in how the T4, which is the hormone that the thyroid produces, and then this is the form that levothyroxine, so the thyroid hormone supplementation, gives to the patient, gets converted to the active substance, which is a T3. That's the one that's active to the cell. So there's enzymes that convert the T4 to T3, and maybe there's an impairment in those enzymes explaining this dissociation. But bottom line, what we do follow to make adjustments in levothyroxine doses is the TSH level. That's the hormone that's made by the pituitary gland. That's what the body as a whole sees. And so that's our guide to adjust levothyroxine doses, aiming for suppression, TSH suppression in most of cases with advanced disease.
You ready? Okay. We have a question in our audience.
Hi, my question is about renal impairment. I've had high creatinine for 16 years since going on vandetanib. Haven't had a contrast CT since then as a result. When I got a referral to a nephrologist, their input was, well, don't take that drug anymore, or don't have contrast with your CT. Does your institution offer any kind of remediation improvement for renal problems, or is it just a don't do that?
So it's certainly patient specific from what I've found. We tend to try to see if we can refer to nephrology to see if we can do any kind of either, as I mentioned, drug holiday to see if it kind of resolves on its own. If not, we tend to either work closely if we can keep the patient on the medication, and if we know that let me try this again. If we give the drug holiday and it brings the creatinine back down, then we certainly know that it's related to the medication. We can either, one or two things, we can either retest at a lower dose to see if it brings it back up, or you don't have a more severe effect, or we can veer and try a different medication. So we do twofold sometimes. It really, in that case, we tend to follow nephrology's recommendations, but not always is it, if you have some sort of AKI or whatnot, it's an automatic, no, don't do that, you can't do that anymore type thing. We try to have options if possible. Does that answer your question? A little bit? Okay.
We have a question online from Sue M. Suggestions to control diarrhea. I have metastatic PDTC. I started on cabozantinib 40 milligrams in June with no side effects for the first 3 months. After watch and wait for 3 years, I now have horrible diarrhea with bad hand and foot syndrome, mostly foot.
Yes. So she's on Cabo 40. That sounds pretty accurate. So usually what we would do is give, again, work with your clinician, but usually what we would do is give a short kind of hold the drug for a couple days and see if it resolves. And then upon resuming of the medication, we would trial Imodium first, and then probably give us prescription of Lamodal and use those to their optimal benefits. And then if need be, we would then introduce like an opium tincture if need be. Okay. More questions?
Hi.
Hi.
So I have one comment and a question.
Okay.
Comment about Lenvima and voice. I don't think it was on your adverse effects. I know the voice is
Correct. Those are just like major ones, but that's certainly one.
right. So it's tough when you get the voice issue and you already have vocal cord paralysis, and lowering the dose doesn't let it go back for whatever reason. I don't
Mhm.
know. Just a comment. Anyway, how often do you recommend that your patients measure their blood pressure? Because we found like really tremendous spikes, like when you measure it like more than twice a day, not just morning and evening, but like, you find like this crazy spike in the afternoon, and
Mhm.
then you take medicine and bring it down. And then another day you can wake up in the morning and your pressure is 90/60. You don't want to take amlodipine in that case, for example.
Right. So I think what we would do is first see how many medications you're on and see the timing of those of the day. So if you're someone that's only on one line of treatment and taking it at night, then I would probably have them start taking it in the morning because it's been in their system, and taking it in the morning and see kind of where their blood pressure is reactionary to that medication. Does that make sense? If they're on numerous lines of treatment, we would kind of probably take it numerous times during the day. I'd probably say like at least twice, probably 3 times to try to capture it.
He's up to 5.
5. We can do
Yes,
it.
you
We can do a
can.
20. Oh, I was going to do the blood pressure monitor.
Yeah,
Go for it. I'm ready.
bring it close.
I wanted to ask another question.
Okay. Is it different than that last one?
Yes.
Hold on one second. Okay, sir. So what we would do is a blood pressure monitor. You can do a 24-hour blood pressure monitor. And we can then see either trends during the day, or if it's, averages, so like daily averages, because as you mentioned, if someone's spiking to 210 over 100, but then also dropping to 70 over 40, I also don't want to add another agent to have them bottom out and end up on the floor.
And who prescribes that? Is that like he's followed by a cardiologist? and-
Cardiology usually.
Cardiology.
Mhm.
Okay, thank you.
You're welcome. Go for it, sir.
I was on 14 milligrams of Lenvima,
Mhm.
and I went down to 10, and I'm doing much better on 10.
I'd love to hear that.
So I have a lot of extra 4 milligram capsules.
Mhm.
Can I take 8 one day and 12 the next?
I mean, could you theoretically? Yes. I probably wouldn't, because here's the thing, right? You could be doing great on 10. I mean, I don't need to go into the nuances of how you felt on 14, but you could go up to 12 and feel awful. You could be that sensitive, right? Theoretically, going 10 and 8 could be fine, but on the days you're feeling that you take the 12, you could feel horrible. And 10 is just your sweet spot, in terms of disease control and side effect profile. So I would say, for non-medical terms, if it's not broke, don't fix it.
But maybe
Right.
I could try it and see how it goes.
I would talk to your clinician before doing it, but yes, you could that could possibly be an option. You're welcome.
Thank you.
You're welcome.
Maybe we'll try to get a quick online one and then we'll be right back. Okay, so online, can you discuss some preventive and treatment options for hand-foot syndrome?
Sure. Yes, I actually skipped over that, so I apologize. So the biggest thing we like to do is urea cream. So anything like Utterly Smooth or those thicker emollient creams. We have patients do that from the get-go. Hands, feet, palms of the hands, soles of the feet from day one. Okay. We have them do loose fitting shoes, not tight fitting socks. Those very good foot care from day one. Other things are if it starts to, from the very beginning, if you start to get any kind of tingling in your hands, redness in your hands, you let us know. We can then intervene with steroid creams. That's the other thing. But in terms of preventative, we have people do the emollient, the urea creams from day one.
In the past, we had many samples of that. I don't know what happened this year because we had a lot of that nice stuff.
I think a lot of us, I'm speaking for my husband, see nurse practitioners more than even the oncologist. So you're the boots on the ground, and we love you and appreciate you. From your point of view, what can patients and their families do to help help them and make your life easier?
I tell my patients, and I hope I don't sound like a broken record, tell me as soon as things happen. So people, even if I see people every week, I always say, even if it's, people are always saying, if I'm going to see them on a Wednesday and they come in and how long has this been happening? Well, it started Sunday night. It started Monday. I was coming in to see you anyways. That's going to be like a quote on my gravestone. I was coming in to see you anyways. Like because 24 hours, 48 hours can sometimes be can make a difference in terms of getting ahead of some of these side effects. Okay. So, and trust me, if it's easy enough to just shoot a patient a message through whatever portal you have, or just make a phone call and say, listen, it's probably not a big deal, but I just want to let you know it's a phone call. I'm not going to get sick of you. And if I am, I'll let you know. I'll say, stop calling me. Stop sending me messages. It's too much. We can address it next time. And sometimes I'll say, listen, we'll address it at the next visit. That's not a problem, but thank you for making me aware. Okay. But I'd rather know than not, because if some people come in and they're an absolute train wreck, and I'm like, what happened? Oh, well, this has been going on for a week. I haven't been able to eat and drink anything, or they have a full body rash. Oh, well, it wasn't a big deal. I put some cream on it and it looked like that guy, but like head to toe, I mean, it's that kind of thing. So again, for you, be proactive versus reactive in terms of telling your providers how you're feeling, like right when it's starting. Okay. That's probably one of my biggest things.
Okay, another question here. How do you manage erectile dysfunction and low libido related to selpercatinib for young males?
So so we usually either have people either go to their PCPs or we have them if they need to go to their oncofertility. If need be, we loop them in with the specialist.
Okay, hopefully they can get a referral for that, right?
I mean, yeah,
Yeah, I mean,
usually it's
I
their
mean, through
PCP.
other facilities. I'm
yeah, but
sure you
usually
got,
it's usually their PCP.
right.
I'm listening.
Hey, yes. I had a question. It's probably a following question from the diarrhea in the setting of cabozantinib.
Sure.
So you mentioned, okay, the patient was on Cabo 40, you stopped the drug,
Mhm.
then once the diarrhea resolved, resume, but before Imodium and Lomotil.
Mhm.
Would you also decrease the cabozantinib when resuming?
So we've done both. Depending on how severe the diarrhea has been, God bless you, depending on how severe the diarrhea has been, depending on how long the patient's been on the medication, depending on how they've tolerated other situations, depending on the hardiness of the patient, depending on their labs, depending on a whole host of things. A lot of times, if we catch it quickly, right, we can have them hold it. If they only had diarrhea for a couple days, we can have them hold it. It resumes really quickly. We can have them restart it on the same dose and then have them start Imodium right away, right? If it's something that they've been having, if they're pretty deconditioned or whatnot, and they have really no reserves or whatever, sometimes we can then kind of slowly titrate up, start 20 for a couple and then go up to the 40 again to make sure that they're tolerating the dose on the antidiarrheals.
And in regards to hand-foot syndrome
Yes.
on lenvatinib, you mentioned about the otherly smooth urea cream and if not steroids.
Yes.
Is there any recommendations for like foot care and what type of, I guess, shoes to wear?
So yeah, so we would suggest not wearing any kind of tight fitting shoes, looser shoes, wicking socks. So something that would, so that way your feet don't get overly sweaty. So it keeps your feet wet. Good. You don't want to use any kind of, what is it called? Like basically sensitive detergent in your laundry. So that way you don't have any kind of like fragrances and stuff like that. When you use any kind of creams anywhere else, you want to make sure that your creams are fragrance free and all that stuff. But basically you don't want to wear the shoes that I'm wearing. Not a good choice when you're on that medication, because you don't, anything tight fitting, not a good choice. Oh, right behind you.
I'm on selpercatinib, and I started having skin issues that mostly on my arms and hands, not on the palms. So I can't say it's the foot. It's probably the whatever else the other thing we had, the edema. But I went to a dermatologist then, referred there, and it seemed to be wherever I had sun. So is that
Yeah.
something that
So a lot of these medications can make you a little more sensitive to the sun and photosensitivity. So a lot of our patients, you don't need to wear, a beekeeper suit, but you need to certainly be more aware of putting on sunscreen when you go outside. If you can wear longer sleeves, you don't want to put baby oil on, that type of stuff. You need to be a little more cognizant when you're out in the stronger rays of the sun, for sure. Because it tends to be, if you're going to get rashes, it tends to be more in these sun exposed areas, for sure. Oh, you poor thing.
Regarding the hand-foot
Yes.
syndrome. So like I have like pain, like weight bearing. Are there any workarounds? Because the creams don't seem to help the actual pain.
Correct.
So are there any workarounds so that I can go back to my physical activities of exercise, which is so good for us? But then, you walk and 10 minutes later, I have to sit down because it hurts.
Sometimes with the pain, a lot of times they can put you on or start some sort of like pain medication. So like a gabapentin or something like that for like the neuropathy pain. So it's like the shooting pain. I'm not sure if you're on that kind of medication, but sometimes they can start you on a lower dose of that, and that can help with the pain that you're experiencing in the bottom of your feet to help get back to walking normally and doing the stuff that you would like to do.
Thank you.
You're welcome.
Yeah, it's not like a narcotic. It'll help with the nerve pain.
So is it too late for somebody who has had external beam radiation to the neck, as well as total thyroidectomy and a neck dissection, and has carotid stents for the gift that kept on giving, and subclavian stent, who has trouble bicycling on a bicycle holding the neck up? Is it too late for PT for that? Never too late.
No,
Okay,
no,
that's great news.
absolutely not.
Thank you.
We'll see who's still hanging on online here. Okay, so the next one looks like Mariette. Is there an oversight of effective interventions for every side effect of the TKIs? I know it can differ individually, but maybe there are interventions that are helping most patients. Does that make sense? That might be too generalized.
Yeah, I'm not exactly sure.
It sounds rather generalized.
Yeah.
Okay, so, sorry, that's a little too generalized. We will, we're going to move on to the next one. Mike F. I am on Lenvima for 4 years now. I had an AFib once or twice a year from taking 300 micrograms of levothyroxine before Lenvima. Once I started on the Lenvima, AFib became more frequent. Lately, it has been several times a week. If AFib is increasing from Lenvima, will a heart ablation help, or will it still happen? Not sure if maybe time to try something else.
I would think if the AFib is becoming more frequent with the Lenvima, I would think possibly an echo and an EKG would be pertinent, and then possibly a cardiology consult would be recommended at this point to make sure, to be quite honest.
Anyone else in the room?
I was like, anybody else?
Yeah. Not we
Do you have any more?
down to the other two. This is for Robert. Are there any symptoms that can get progressively worse or show up years later from radiation or TKIs?
I think, Robert, if I'm reading your question correctly, I would think that sometimes with these medications, the longer you're on them, sometimes you can have more increased side effects. Some people, I think it's patient specific, to be quite honest. Some people can be on, the lowest dose and have really horrible side effects. Some people can be on a higher dose and for a very long time and experience very minimal side effects. So I think it's really a patient specific thing in terms of timing.
We're going to skip one question and just go to this for Sue. Can holding, I guess, any drug, the drug for 1 week be detrimental to your treatment? How long does the drug actually stay in your system?
So I'm going to do the second question, part of the question first. So each drug has a different half-life. So it would be different in terms of how long it stays in your system, depending on what drug you're on. And then holding the drug for 1 week will be detrimental to your treatment, to be quite honest. In the long term, most likely no, because if you're experiencing horrific side effects and you stay on it, it's going to be more detrimental to you in the long run. So giving you just say a treatment holiday of a week, not awful at all. So.
And the other question, do you know what percentage of your patients on selpercatinib take less than the full dose? And has there been any downside to reducing the dose?
I do not know the exact percentage. However, the ones that we have dose reduced are still seeing an effect, a benefit, because we wouldn't keep them on a dose reduction if they're not on a benefit.
I believe we're done here for now, plus we're out of time. So I guess that's it. Thank you.